according to my watch, we have a few minutes for a discussion of these talks. We have any questions from the audience? If not, let's start at the top. The spinopelvic fixation, are you doing that? Well, two questions. Many of us work in community hospitals. So when you say call the spine guy, a lot of us don't have a spine guy. So if we recognize a cauda equina injury in the emergency room, what do we do?
So that needs to be transferred to someone who can take care of it. So for cauda equina, the outcomes are, within 48 hours, and so within 40, if you don't get to it within 48 hours, the bowel and bladder recovery is pretty much, is pretty limited. And for these injuries, if it's associated with that sacral kyphosis, the reduction needs to happen at the same time.
So we have a young patient with the proper mechanism,
Yeah.
with X-rays and a CT scan,
Yeah.
in the emergency room, and we've done a physical exam, so we've
Yeah.
recognized
Yeah.
that they have a problem.
Yeah.
Do we do anything else?
No, I mean, I think just trying to get them decompressed as quickly as possible. Where we run into problems is when the injury isn't recognized. So anytime you see that transverse fracture, it's worth doing a rectal exam, just because on the trauma survey, what our general surgery colleagues are looking for is just blood in the vault. They're not really assessing for sensation and tone. But in terms
So
of
other than resuscitating the patient and making sure their
yeah.
ABCs are all taken care
Yeah,
of.
but just if you suspect that the injury is, if you may have an acute cauda equina, is just to assess, usually for a rectal exam, a PVR is also helpful. And then if you don't have a spine colleague who could take care of it within the next 24 hours, the patient should go to somewhere that
At that point, we pick up the phone and call the transfer service. Right? Okay. Trig?
Yeah, I've got a question for Ash. On the lumbopelvics, are you taking the hardware out since you're not fusing?
Yeah, for the ones that I don't fuse, it's sort of treat them similar to our syndesmotic screws, where I'll either counsel them that the hardware is going to break, or if they want the hardware out. But you just need to talk to patients ahead of time, or I'll get a CT scan, usually around 9 months, and remove it. So in Bella Barba's series in 2006, for the high-grade spondylitis treated with the open lumbopelvic, they didn't routinely take out screws, and a fair amount had asymptomatic hardware breakages, which is expectant, similar to how we treat like syndesmotic injuries.
And question for Kyle. You've got a really bad limp. I've got a clinic.
It's called a swagger.
Okay.
It's not a limp.
We can get some
Being
x-rays.
from Texas, you should know that.
No, and Andy'd be happy to do a total hip on you. I think, is it your left hip or your right? I can't tell.
Actually, the knee, but that's close.
It's like the hump in Young Frankenstein. It changes, sides. Great. Are you doing this stuff with nerve monitoring?
I am not, I think Rout has a good paper from his time in Seattle where he looked at the utility of monitoring for posterior pelvic ring stabilization, and there weren't too many points at which it's actionable. I think, you could, there are some cases where if there is a allosacral comminution, there are some, we have one in the hospital. I was talking with one of my colleagues, Dr. Shearer, earlier today, where there does look like if you're concerned that you're going to displace a particular fragment into the foramen, then it may be worth sort of assessing, but that's usually not the standard
How about
care.
in patients who are already exhibiting a neurologic injury? Are they at higher risk for you injuring them?
Well, the
further?
ones that I'm most concerned about are the patients who are intact, and so, yeah, and it's hard to because the neuromonitoring at the sacral level is the only thing you're really monitoring is is the sphincter.
Yeah.
And with the sphincter, if the tone is intact beforehand, then you really need to. What we know from the oncology literature from the 70s is you really need to knock out a lot, like almost, because you could do a hemi, pelvectomy and still maintain function. So I typically don't do the, don't do neuromonitoring. The other thing is for these high-grade lumbosacrals, the patient needs to be relaxed because you're trying to do everything that you can, and you can't monitor motors if you have sort of relaxation on board.
Good, thank you. So I hate to put Steve and Kyle together, but it seems to me the way to avoid operating when you shouldn't be operating, and to avoid disasters is truly understand the injury.
I agree.
Am I with you? So those of us who may have forgotten how to assess pelvic and acetabular fractures or never learned, how do we do that? What do you think is the best mechanism? Do we get I have a white model pelvis at home. I can draw on it. I've gone to pelvic and acetabular courses. Amir said maybe next year we'll have cadavers when this meeting's held in Tampa. But if you don't have that experience, if you don't have that experience, how do you get it at this stage in our careers?
We can both comment it together. No. Unfortunately, Letronel's book's out of publish.
Is that right?
But
Is that
yeah,
a print?
it's out of print. Yeah, so it's hard to get that. But anybody that wants it, I have it downloaded. Forgot the guy's name in Australia did it, and I think going through that is probably the best thing you do. But also, what you said is absolutely true. You got to draw it out and understand it. And it took, I had some smart fellows, Joe Shue, he said it'd take about 30 before he could actually draw it out correctly. And so just going through fractures and drawing it out and, going through his book, I think would be the best way to do it. And
Yeah, we had a great experience with trying to draw it out preoperatively, getting in there, seeing what it really was, and going back and seeing what we thought about it.
So I would agree with that. And I think it depends, your question, Joe, a little bit on whether you're someone who's going to refer it or you're somebody who's going to fix it.
Yeah.
Because there are different levels that you need. But I think if you're going to fix it, the thing to do is, as you pointed out, Kyle, is to draw it out. And I think at first it's particularly helpful to draw it out on a 3D model because, Mata used to always talk about it's not so much the lines on the surface, it's actually the plane of the fracture. So it's sort of where does it go through the bone? Because you're ultimately looking at one side of the bone, whatever approach you do. And you have to understand where the fracture line is on the other side of the bone and what is the plane and how do you get perpendicular to that plane for your fixation and your reduction and everything else.
But you'll agree, there's no shortcuts. You got to get good plain films.
Yep.
You got to get a good CT scan, and nowadays we have three-dimensional CT scans, and I think that,
Which is sometimes helpful and sometimes not.
yeah.
Sometimes it makes it look easier than it actually is. So.
Are you going to chime in on this?
Yeah, I was going to ask about the utility of drawing it out. If I could just push a button and get a 3D CT scan that's high resolution, and is more accurate than whatever drawing I would make.
he was a bad resident too.
Yeah, but,
I mean, you welcomed all the questions, and this is just another question.
It's great if you're going to describe somebody else what it is, but it's bad if you're going to understand it.
and as Dr. Olson pointed out, we only have fluoro in the operating room. Not all of us have a CT scan. Most of us don't have a CT scan. So we have fluoroscopy, so you have to understand those x-rays.
And I spend a lot of time even now drawing it out. And the reason is you can get a 3D, but that still doesn't give you the plane of the fracture. And, one of my favorite cases with Mata is I said, may I? And you just change the time, like 2 or 3 millimeters, and it just reduced. And I don't know if you get that with the 3D.
I don't think it's going to hurt you to draw it out. It is time consuming.
I mean, my feeling is you get as much information as you can from wherever you get it, and you use that as a way of, figuring out what to do. I wouldn't discount, I like the 3D reconstructions too. I like seeing them and see what they look like. Sometimes you can see where the hinge is. A lot of times the issue is like there's a hinge point that you need to derotate. And sometimes you can see that well
But
on
that's
the
not necessarily
3D.
where you would start your analysis.
Yeah, I mean, it's always X-ray, regular CT, and then, eventually, if you have that, I don't see any reason not to. You don't lose anything by doing that.
Yeah. So Andy, I was right with you until the very last.
How many times I've given the talk and I never noticed that?
But
I totally agreed with the ORIF at the end. I thought it was a mistake that I may be stuck in.
I don't
Early
wanna-
ORF.
I don't want to give anybody the impression what you said was, don't waste your time fixing posterior wall fractures.
No, not at all.
Right. Even in some of the older patients, without the head injury, without the impaction, don't waste your,
Right.
even if 50 to 60% don't do well, 40% are doing well.
Yeah, there's both sides of the coin for sure. And yeah, you can fix these. And you got to put it all together. I think that nomogram has been helpful, especially when I'm doing shared decision making with patients. I can show how all these things, because if you're in that 68, 70-year-old age range, that you're halfway there already just because of your age. But no, I mean, it's funny, because even with just Dave Tupperman and I working on these, we sometimes argue where he'll send me one that he thinks needs a total hip, and I'll say, no, that one needs to be fixed, and, you know.
Is that right?
We go, you know, because sometimes it's what you think you can do, and I have one case where he swore it needed a total hip, and I just fixed it, and the guy did great. So every time you argue with him, I just show him that case. Well, Dave, you know.
And it's much more than age, it's physiology as well.
Yeah, and the thing I struggle with is sometimes you just, I mean, I remember early in my practice, you'd tell patients, well, I'm going to, you know, I'll be prepared to do this or that,
Yeah.
and, you know, but I really have trying to get away from that. But you do sometimes when you're operating on these, when you're doing total hips, you take the head out and you see, you know, some pretty significant chondral damage in some of these cases.
And
then-
some of us up here are familiar with chondral damage.
Right.
Amir, what does the STAPA approach offer that the ilioinguinal doesn't?
You don't have to take down the inguinal ligament. That's the first thing. So you don't have that middle window dissection. You don't have to do. People think that there's a problem looking at the anterior wall, but I totally disagree with that. I think you can see the anterior wall pretty easily, and you can come down right on it with the retraction, so with the flexing the hip and the knee. So I don't think that's a problem. So my only the only time that I do something different is if I have a higher kind of wall fracture. And so in that particular case, if I need to come straight down with an AIS for whatever reason, I'll do the extended Smith-Pete basically. So I'll do a Smith-Pete and come down this way, and then again avoiding going through the inguinal ligament. And honestly, I personally have not done this approach for 18 years. Inguinal approach, a full inguinal approach.
Joe, have a question. So Amir, when you flex the hip, the thing that, and I appreciate that you can do it in your experience with it, but my question has always been, you know, to reduce the hip, regardless of your approach, you have to have traction through the femoral head, particularly lateral traction. So how do you flex the hip and then maintain lateral traction?
Yeah. So when you put a triangle under the hip, you can still put a troch pin and go straight lateral. So that's what I do. And we have really strong fellows, and they don't smoke, so it's, you know, so they can pull.
They reviewed the
That's
3D
basically it.
CT.
So what I do. That's what I do. What I do is I put the triangle under the knee, and that gives me my hip flexion and my knee flexion, and then I can pull straight, essentially, along the femoral neck.
So it's probably important for everybody in the audience to understand, you know, what Letournel talked about was restoring the bone from posterior to anterior. And what Amir is talking about is reducing the joint primarily, regardless of that. And then once the joint's reduced, then attaching it. So it's a slightly different approach.
Yeah, and the reason, and that's exactly what you see in the video as well. That's what happened in the video. And the reason why that is because I feel that, like, sometimes if I make a small, tiny error far away, by the time I get to the articular surface, it's magnified. And so maybe I'm not as good as, you know, other people who can do it the other way. So I feel like the articular surface is the most important part of the whole thing, and I want to restore the articular surface and then attach it to the rest of the pelvis. So that's how I think about it.
So,
It's almost similar to the hand talk earlier today, where the hand surgeon said 1 degree of malrotation at the metacarpal made a 5-degree change at the finger itself. Yeah.
so the other problem, just because Steve and I are attached, there's those
Should I walk over?
fractures that have a posterior wall injury that's part of the quadrilateral surface. And can you get that through a STAPA?
No, I mean, in those cases, if I can't get something from the STAPA, I'll do a front back. I'll do a dual approach.
So those are ones where the middle window is very helpful because I can look down the fracture site, see those, reduce it. And I was surprised, you know, I had a good number of those that you can't see through a STAPA.
Great.
Nice.
Well, great discussion, great experience up here. Don't be afraid to talk to them at the reception.